Beautiful. Okay. Shanitra, can you hear me? Okay, just checking. Sorry, I'm a couple minutes late. I wanted to be here in time to make sure that I introduced our amazing fellow, Dr. Lindsay Vendetta, for her grand rounds today. This is, quite momentous because all of our fellows are starting the last part of their journey as palliative medicine fellows. And these projects, these grand rounds, which thank you so much for joining us this morning, really mark a big achievement for them. And I love kind of seeing their interests and things that they've narrowed down on their focus on to kind of act as almost like a capstone for their year, their grand rounds presentation. So I don't want to take any further time away from what I think will be just a really great experience this morning. So thank you so much, Lindsay. Thank you so much, Howard Gross. I can't wait to hear your presentation, so take it away.
Thanks, Annie. And yes, I have someone else to introduce today. I'm accompanied by Howard Gross. I met Howard actually as a patient at a CCA palliative care clinic. And throughout the past few months, it's become quite clear that he is just one of those patients that completely transcends that typical role and has become more of a teacher figure for me. Today, he graciously agreed to share his own story about how the arts have aided in his ability to cope and regain control of his illness. My plan is to dedicate the entire second half of this talk to Howard's experience, but I wanted to introduce him now. I know Howard is open to answering questions, so feel free to write in the chat box as I share background information in the beginning or when Howard is sharing his story and some of his art. That'll help us have a meaningful discussion at the end of the hour. And Howard, I'll introduce you again when my part's over. I just wanted to make sure everyone knew you were here now. The title of today's talk is Beauty from Darkness, What the Medical Humanities Can Teach Us About Life, Death, and Ourselves. We're going to talk about storytelling, but from a much broader lens than just how we use narrative medicine on a daily basis as palliative providers. Today, I'm using the example of visual art, but we could really insert any form of art into this conversation, and you have my full permission to talk about or even to share your other artistic endeavors during the discussion. And then one last thing about this slide. The photo comes from a book called Hidden Beauty, Exploring the Aesthetics of Medical Science, and it was one of the early inspirations for this talk. It's a project that's a collaboration between a pathologist and a medical photographer who were inspired by the fact that on a daily basis, their professions forced them to process the complex space of images that were both awe-inspiring for their beauty and for the terror they might represent to their patients suffering from disease. This picture is of a meningioma, but I almost think that it looks like an intricate bouquet of flowers. If you're looking for a good coffee table book, I recommend checking this one out. There we go. So I couldn't help myself, and I also needed to include two quotes from people who have been an inspiration to me. This is an Elizabeth Kubler-Ross quote. And it reminds me of how as palliative providers, oftentimes our job is to help patients and their families find their light. But I've also learned throughout this fellowship year that patients and families can also help us find our light. And this is a Da Vinci quote. So I grew up going to Catholic school, and I didn't find it to be the most comforting environment. The Renaissance art that I was often exposed to ended up being a source of comfort and beauty for me as I tried to process the theme of death that was often incorporated into our lessons. And then I included with this quote a painting done by Rembrandt, who was also inspired by Da Vinci and depicts art students learning through the use of cadavers. So here are the objectives for today's talk. By the end of the hour, I hope we can all recognize the coevolution of palliative care and medical humanities as it pertains to the US. We'll illustrate the art of narrative medicine beyond history taking. We'll identify how the humanities can be applied to palliative care, which I've separated into 3 big groups impacting the learner, the provider, and the patient. And then lastly, we will uncover firsthand patient experiences. I'm going to start by talking a bit about how the origin of medical humanities and palliative care are similar and how this has impacted the development of these fields in the US. There's not a lot of literature available that integrates these topics, but I tried making a simple timeline that reflects the parallel development of the fields and how they're related. So in the 1950s, America witnessed the rise of the modern hospital and expansion of biomedical research and medical technology. A few key examples include the development of life-prolonging technologies such as mechanical ventilation, dialysis, and organ transplantation. As a result of these amazing advancements, we also needed to learn how to adapt to this new delivery of care for the seriously ill. Moving on to the next decade, you can see that the first modern hospice, St. Christopher's in London, started by Cecily Saunders, and the first Department of Humanities at a medical school, Penn State University, were interestingly both established in 1967. And to stick with my theme, Cecily Saunders actually married a professor with a degree in fine art, and this was after becoming familiar with his paintings. And then he went on to set up an art studio in St. Christopher's Hospice, practiced painting there for many years, and I hear there's still a lot of art around there today. So throughout the next few decades, the term palliative care is coined in the 70s. Then the first palliative care service is formed at Cleveland Clinic in the 80s, and it's finally recognized as a board certified subspecialty not too long ago in 2006. To parallel this history, more departments of humanities and social medicine are formed, like the Institute of Human Values. Journals like Literature and Medicine and Medical Humanities are started. And these changes were also slowly starting to reform medical education to be more patient-centered as well. So it was becoming clear that the advancement of medicine, starting in the mid-20th century, was great for so many obvious reasons, like longevity and vitality, and that we were experiencing less sudden deaths and death at younger ages, which is my interpretation of what Stokes is depicting here. But these mid-20th century advancements also introduced some new challenges to medicine's moral and humanistic core, and unexpected chaos and suffering resulted. This is Picasso's Guernica, which was painted in response to the bombing of Guernica during the Spanish Civil War, and is not meant to be about these changes in healthcare delivery that I'm talking about. But the painting reminded me of some of the negative themes we appreciate at end of life, such as loss of control, turmoil, shock, and fear, and how modern medicine can sometimes heighten some of these emotions and experiences. Another shift to point out is that we were starting to view illness and death as more of a biological process and forgetting about the biographical aspects of care. We were also starting to use our new medical knowledge to separate mind from body. These technological advancements changed the experience of death into more of a slow loss of human abilities with more time to reflect on our lives. Today, we have more of a struggle with being aware early on about unstoppable conditions, or even with the march of aging. And what we see time and time again through our work as palliative providers is that human beings want to keep shaping the story of their lives, to make choices, and to sustain connections. I love this Gustav Klimt painting, and to me, I think it perfectly depicts the collective change to a more slow and thoughtful death, which can often be filled with connection and beauty, as well as sadness and grief. It also reminds me of the comfort quilts that we have the privilege for selecting for our patients here at UW. I hope that by this point, I've depicted that part of the rise in the fields of medical humanities and palliative care was a response to the same shortcomings of a medical culture dominated by scientific, technical, and even managerial approaches. And this is the part of the story when we really learn to value the art of narrative medicine and to see the power of storytelling come alive. Fortunately, the practice of storytelling in medicine has become more widely accepted, partly because more comprehensive and humanistic care has been shown to improve healthcare quality and outcomes. But storytelling also brings together patient and provider and allows us to recognize and interpret our patients' stories of illness and to integrate these stories into our medical practice. As a result, we're able to bring greater empathy, dignity, trust, and confidence to medicine. What makes the practice of narrative medicine even more important in palliative care is that we're usually accompanying our patients in their final chapters. Even though the ending of a story is important, it's equally vital to reflect on the peaks, the individual acts, and the sense of a whole. This practice helps us come to grips with our own mortality and to answer some of the hard-hitting questions like I've listed on this slide. So from here, I'm hoping to apply the history of medical humanities and the principles of narrative medicine to the idea of further integrating the humanities into our work. If I can convince you of anything today, it's that the humanities do not augment medicine. It's more the other way around. The humanities give our lives beauty and purpose and meaning. Medicine keeps us healthy so that we can continue to enjoy what makes life beautiful and purposeful for as long as possible. One might even go as far and say that art is medicine. I think having this shift in perspective is a helpful approach for making our work more meaningful and sustainable. So now I wanted to review a few ways that the humanities can fit into palliative care in both academic and practice settings. And to repeat what I mentioned earlier, I'm using visual art as an example, mostly because this medium is easiest to share on Zoom and PowerPoint, but everything I'm talking about today can be applied to the broad definition of art. And I could have also used examples from dance, theater, poetry, film, the list goes on. So after doing some reading, I separated this theme of art and palliative medicine into a few categories, which we'll now explore. There's the impact on the learner through studying the soft skills of medicine, the impact on the provider through advancement of critical thinking, self-care practices, and awareness of biases, and the impact on the patient through examples such as community making, creating order out of chaos, and legacy work. When looking through the literature, it is clear that art has been most accepted as a form of education to nurture empathic, patient-centered, and compassionate physicians. A scoping review looking at art and palliative care found that half of the studies published on this topic from 1997 to 2015 focused on the development of practical and technical skills relating to clinical medicine. Role play was the most commonly used intervention, which I'm sure most providers on this call can relate to as part of medical training. But I found it interesting that the theme of visual art appeared second most frequently in this study. I included part of figure 3 from the scoping review, which is a radar diagram of intended outcomes of the primary studies they examined. It really stood out to me that the visual arts encompass everything role play misses and that a mixed approach seems to be the most well-balanced in terms of addressing the areas of skills, personal development, awareness of self and others, and empathy. One way that I saw visual art used in medical education specifically was through practicing observation and reflection skills at museums. A paper that stood out to me initially was called Palliative Care in the Arts, Introducing Medical Students to Patient-Centered Decision-Making and the Art of Caring, which detailed one medical school's approach to introduce palliative care-related content into the medical school curriculum. I included table 1 from their paper, which details their program. They hosted a voluntary 6-day course for medical students across all years, and it consisted of introductions to pre-selected artwork, and then the students were asked to reflect on what they saw in each piece, asked what it represented to them and what their emotional responses were. And then following those sessions, further integration occurred as classroom-based learning, which was facilitated by interdisciplinary educators and included case-based scenarios, didactic overviews of the topics listed in this table, and reviewing videos highlighting communication techniques. And then this curriculum was evaluated through mixed methods, which included open-ended questions, a Likert scale survey, and a focus group. And I wanted to read to you some of the key learning points for the medical students, which was part of the results of this study. So the students noted that palliative care is complex care and is provided to people throughout the entire illness trajectory and not just at end of life. They learned about holistic, multidimensional, patient-centered care and how this relates to decision-making. The students learned how to better detect and respond to emotions. They saw the reciprocity of their own humanity and that of their patients. They witnessed listening as a therapeutic intervention. They saw decision-making as an individualized, personalized solution to problems that are uniquely defined by the particular circumstances, values, and desires of both the patient and family. And they learned to view physicians as advisors and companions and saw the value of multiple perspectives in a team setting. So for frame of reference, I hadn't even heard of palliative care in medical school. I think this is an impressive example of how palliative care concepts can be introduced to medical students in an efficient, innovative, and impactful way. So I'd be remiss if I gave this whole talk without acknowledging Lee Burnside's contributions to medical humanities related research within our own community here at UW. After reading about this 2017 museum study with medical students, I learned that Lee executed something similar right here in Seattle and with last year's class of palliative medicine fellows. And after doing my own reading and talking to Lee, it became clear that his project helps to fill a gap I started to appreciate based on my own lit review, in that it provides insight into how more established physicians can benefit from exposure to arts. He sought to assess the impact of using a formal method of art observation and reflection on improving the skills of understanding psychosocial, spiritual, and emotional contexts of illness, which as an aside is part of ACGME criteria, and he honed in on using art as a self-care practice. He used the concept of visual thinking strategies to advance these skills at the Fry with an educator trained in these techniques, and he did this for 3 90-minute sessions with last year's fellows. Even though this study is not yet complete, Lee gave me permission to share some of the fellows' experiences with this project. So the fellows noted that it was nice to practice seeing and describing experiences outside of the medical paradigm, and that it gave them something to value beyond medical data. One of the fellows shared that they were struck by how their own perspective in life informed their view of the art and how that applied to informing the care that they gave to patients. They found that the mindfulness practice helped with self-care and that it was even nice to know about a place in the community where they could practice said self-care. They thought it was really beneficial as part of the fellowship curriculum and that it served as a nice way to connect with their co-fellows. And then the theme of representation in medicine seemed to come up frequently, specifically being a woman in medicine. So overall, this experimental curriculum seems to be beneficial in self-reflection on personal identity and values, being present, and understanding the diverse view of others. They thought that there should be a way to incorporate this into the work week as opposed to the weekend, and that it'd be great to do this with an interdisciplinary team. Hopes for future directions for this project include formally embedding didactic sessions into the curriculum as part of clinical competence, different forms of art like reflection, and even inviting palliative attendings and other medical specialties to participate. So this brings us to other ways art can aid our work as palliative providers beyond the educational component, such as team building, improving interpersonal skills, self-care. This section, I think, is most pertinent to those who are on this call today. And as mentioned earlier, I think this is the area where research and funding are lacking. Art has been shown to be helpful for healthcare professionals because of the safety it can provide through enabling access to a story world. It's a way to distance from actual practice. The scoping review that I mentioned earlier cites some studies that reported psychological safety as the primary intention, specifically with regard to emotional and social well-being. Safety was provided not by avoidance or detaching participants from emotions, but through creating a safe space and non-judgmental atmosphere in which participants were free to feel and express themselves. This makes me think about all of the various ways we debrief within our own team and with other teams. And I wonder if we could use more art throughout this process. Similarly, art can also aid in team building and collaboration, whether one is participating in an active or passive role. During the AAHPM conference this past year, they actually featured an art therapist, and they went through a creative activity that involved drawing representations of negative feelings or experiences on a piece of paper, and then ripping the paper to pieces and redisplaying it in a way that promoted more positive feelings. And it was amazing to see how impactful and personal this hands-on process was for hundreds of palliative providers, even on Zoom, and even when not necessarily asking for art therapy. Another simple impact art can have on healthcare professionals that shouldn't be understated is simply providing enjoyment and engagement, especially when the experience of art resonates with an individual on an emotional level. The Palliative Fellows participated in spiritual care rounds throughout the year, and I remember during a particularly dark time that Catherine and Leah showed us beautiful images depicting the winter solstice, and it inspired a great conversation and a completely new perspective on a difficult moment in fellowship. And the way art can shift our perspective has even greater implications than just being able to help out some palliative care fellows struggling with December's darkness. Art aids in learning about new perspectives and gives us better awareness of ourselves and others. Reflecting on stories brings our biases and assumptions into focus. Through this process, art can help us think differently about human history, culture, behavior, and experiences. I wonder if the practice of maintaining an open mind through passively and actively enjoying art might help with some of the moral distress that we see so commonly in our work. And I've also been wondering more about the role of art as we advocate for equity, diversity, and inclusion in our work and personal lives. So I wanted to talk a bit more on this representation piece and to share with you another member of our community, Andrea Gahl, who's one of the Harborview TICU nurse coordinators, and she's also a brilliant painter. I wanted to encourage you all to check out her series, I Look Like a Surgeon, which focuses on visual representation, how it shapes our perception of the world, how we see ourselves, and how we perceive the people around us. This series challenges typical representation medicine, particularly surgery, with the most beautiful portraits. I love that Andrea wrote her own story to illustrate the beauty of diversity and how we should embrace it. I don't want to speak for Andrea, but as someone who only briefly experienced the intensity of the Harborview TICU this year, I can only imagine that visualizing and representing these young surgeons as a whole person served as a way to introduce more humanity into her incredibly difficult work. And if you look closely through this series online, you might just see a past palliative care fellow too. And so lastly, for this professional and personal development piece, I wanted to talk a little bit about art therapy, since I think it's important that as palliative care professionals, we understand this field and how we can collaborate. I also think understanding and advocating for this field is more important than ever as we go through a mental health crisis and process the collective trauma associated with the pandemic. Art therapy is defined as a mental health profession that enriches the lives of individuals, families, and communities through active art making, creative process, applied psychological theory, and human experience within a psychotherapeutic relationship. Art therapists are clinicians with master's level degrees or higher, and they're trained in both art and therapy. I found a report by the American Art Therapy Association that investigated how art therapists were responding to and coping with the pandemic. And they surveyed over 600 art therapy professionals about this time last year. And they found that half of them were still going into work and considered essential workers. And then when asked how they'd explain their work during the pandemic to others, a few quotes stood out to me. So one art therapist said, "Most people are experiencing a collective trauma and loss of normal at this point during the pandemic. To process the trauma effectively, a bottom-up neurological approach is most effective. The higher cognitive processes of the brain don't function as well during a trauma. Art therapy and other creative arts lend themselves to expressing, incorporating, and then fully processing the material to heal." And then one other therapist said quite simply, "Art therapy allows for the fear to become an object that can be explored and manipulated." I included on the slide 2 paintings done by art therapists that was included in this report. And I think it just beautifully highlights some of the experience and impacts of the pandemic, and all amazingly without words. This report by the American Art Therapy Association also included a bar graph, which I found interesting. I had never considered the question, who do art therapists see, prior to preparing for this talk. I love that almost half of art therapists in the past year have been able to do grief work, but seeing hospice, cancer, and even veterans at the bottom of this list left me with the feeling that there's more room for future collaboration. And so lastly, I wanted to expand on the thought of thinking about the future. Before we dive into the patient experience part, which I'm really excited about, I wanted to summarize my piece with a few conclusions and offer ideas for ways we can further integrate the humanities into our work. In terms of conclusions, it's clear that the medical humanities are valuable and add an important humanistic element to our work. The arts and sciences share a common aesthetic of discovery through observation, and the arts and palliative care share a common foundation of connection, understanding emotions, and fostering relationships. We reviewed today how art can serve as a conduit for palliative care education and staff development, and we're about to continue our conversation with how art can impact our ability to cope with serious illness. What is less established is how collaborative art and palliative care programs function and how limited time and resources can be factored into advancing this work. So I tried composing a list of some practical ideas and maybe some more hopeful ideas for how we can further incorporate art into our work. In terms of medical education, I think it's important just to alert all of the amazing educators here today to this area of study and to share that there are examples of this type of curriculum on the internet. Role play is already integrated into medical education. I wonder if we can use this as an opportunity to add another component of the arts to an educational approach that already exists. Can we tweak the way we already train? We can advocate for more creative spaces and community engagement. I love the idea of displaying local art and patient art in our clinical spaces. I'm curious about starting the practice of more explicitly asking my patients about how art impacts their lives as a form of relationship building and nonverbal communication just in my daily practice. I'm left thinking with ways about how we can collaborate with art therapists in the future. Even though my only exposure to the UW system is during pandemic times, it seems as if prior to that, there's really only been support for art therapy in the pediatric setting. And then simply put, we just need more research and awareness on this topic in general to be able to get more funding for programs. And so with that, I've shared all of my points and I'd like to introduce you all to Howard again. Like I mentioned, I met Howard while working in palliative care clinic, and I quickly realized that he taught me so much through his use of narrative medicine and personal exploration with art. And I'm so happy he was willing to join us today to share more of his story. So with that, I'll stop sharing my screen. And then Howard, if anyone writes you questions in the chat, I can help facilitate.
Great, thanks. So let me just play with technology and get stuff loaded here. Okay, are you able to see my screen? Okay, and then I'm seeing, my image on my screen. Do you see that on the screen? I don't know if it's blocking my slides at all, or I'll assume not. Okay, so thanks again for this opportunity. I've had this amazing experience with Lindsay and the palliative care team, and really what's been amazing about this journey is they've shown me what medicine is all about and how to really take care of people and deal with medicine the way it should be done from my perspective, from a patient perspective. I was going to get into a detailed story about my history, but I'll give you a quick summary and really want to talk about what I feel is helpful from a care perspective, from a provider palliative care perspective across the board, how that helps a patient's journey. So my background, had 2 bouts with cancer about 22 years ago. I had sarcoma, spent about 2 years getting treatment, including radiation, chemotherapy, and surgery to remove the fibula from my leg. As a result of that, I actually had a number of years ago a tibia fracture because the leg was unstable and my leg split in two, and I was in a wheelchair for 6 months. So I spent about a year in a wheelchair, which gives me an incredible perspective of what it feels like to have that disability and be in a wheelchair with the benefit of not having to live permanently in it. So it's a great gift of being able to step into someone else's shoes or wheelchairs in this case and be able to experience that journey without knowing that you have to live with it for forever. Most recently, over the last 3 years, I've been dealing with cancer. I was originally diagnosed with stage 3 cancer, was treated for about 8 months. They thought that had resolved, and about 3 months later that returned, and I ended up being diagnosed with stage 4 colon cancer. So that's what I'm currently being treated with. So as I take you through this journey, it's my journey, and the critical thing is really understanding the patient's journey, letting them own, control, and transform that experience, meeting the patient where they are, let the patient control the journey, being their coach, the mentor, their consultant, their cheerleader, helping them on the journey with the right level of support needed for that particular patient. And as Lindsay was talking about bereavement, one of the things that I've realized over the last number of years is so much care is needed for the caregivers. And most of the time we often focus on the patient, but it's really focusing on what are the needs of the caregivers and how do you give them what they need in order to navigate this experience, feel confident that they know what to do, and not be overwhelmed by that. So giving them the support and always making them feel like they are in control of their destiny. So let's do a deep dive into the owning, controlling, and transforming elements of cancer here. So as I said, I was diagnosed with stage 4 colon cancer. The survival rate for that is 14% will survive for 5 years after they've been diagnosed. So for any patient who hears the word cancer and caregiver who hears the word cancer, it's a tough word to hear. And it's often why people whisper the word cancer very silently so you don't hear it. In my world, it really started with the whole concept of owning what I have, accepting what I have, and then figuring out what to do with it. So if you sit there, I don't know if you do a deep dive into the Kubler-Ross thing, you get into all the denial and all the other steps that take place in that process. But owning what you have so you can do something with it, as opposed to denying it, avoiding it, and letting it own you. So I wrote this little spoken word thing that kind of defines this in a broader context of a disability. I own my disability. An ear with no sound, an eye with no sight, a leg with no gait, a mouth with no voice, a mind with no memory, a body with no energy, a life with no time. This is what I have. This is what I own. My disability doesn't own me. I own my disability. So as a provider, just helping somebody be comfortable with owning it and then figuring out how they get to the next step of being able to control what's going on. There's certain things you can't control. You've got a diagnosis. When you're given that diagnosis, even though you don't want to hear it, it's there. You have to accept it. You have to realize that's the case. You can't control your odds of survival. You hope that you defy the statistics and are not in that category in terms of your lifespan, but it's what statistics say, and you have to live with that. There's a lot of things that you can control. You can control where you seek care, who your doctors are, the treatment choices, your pain management choices, your attitude, and how you spend time as you go through this. Some of the things that I really struggled with when I was going through my treatment, I was on a clinical trial that turned out to not be the right approach. But I felt like I was losing control because I had lost my voice and wasn't able to speak for a while. And people who know me, I like to speak a lot, and probably it was a good thing that I wasn't able to speak for a while, gave them a little bit of peace and quiet. But just that sense of losing voice, the inability to communicate. My feet were swollen for a number of months and I wasn't able to fit my feet into shoes. So I wasn't able to drive, I wasn't able to walk, I wasn't able to exercise. I lost strength, body strength, so I needed to get help getting off the couch or the toilet. So things like that really resulted in me feeling like I was less human, not whole, and wanted to be able to find some way that I could control what was going on. Just a little aside, for a while, I did some consulting work with a medical group that does medical clowning. And I don't know if anybody's seen that. It's kind of memorialized in the movie Patch Adams a number of years ago, worth seeing. But it's the whole concept of if you're a patient, oftentimes things happen to you. Patients are being told what's happening and they have no control. And the medical clowns, especially when they come into places like Seattle's Children dealing with cancer patients, it allows the clowns to be the things that the kids can do something to. So they can hit the clown and knock the disease out of them. They can do a dance with their IV that they call IV as a dance partner. And it gives control over your situation. So getting control is critical in this world. And the last thing, which is where Lindsay and I started to do a lot of our conversations, is transform. So I came up with this quote as I was going through this: is art creates what cancer takes. So cancer is taking things away from you, the control that I spoke about beforehand when I lost my voice. I realized, I wasn't able to tell my story in spoken word, but I could do something in a visual format, and it gives me control over that situation. So seeking to gain control by transforming something nasty and painful into something beautiful and engaging. You can't control the disease. However, through spoken word poetry, comedy, or art, you can choose to transform something that is nasty and painful into something that is truly beautiful. So I'm going to try do a quick video clip here, and if it doesn't work, we'll get back to the other stuff. But when I originally had my stand-up comedy, as I was sharing with Lindsay in our prior discussion, the beautiful thing about it is it gave me a lot of time to actually do the things I liked doing or wanted to do. So most of my life, I always did things as my family wanted me to do, because it served my professional goals or my professional needs. When I got cancer, people were not questioning me the first time, questioning me about whether I, oops, sorry, on video now. So nobody was questioning me about whether I should be taking classes that I just enjoy taking, or as opposed to taking classes that I wanted to take. And one of the things I always wanted to do was do comedy, learn about art, everything else. So I'll share a quick clip with you. Hopefully you'll hear the audio. Lindsay, you'll let me know if we can't hear the audio. One thing I wanted to just reference in here is originally from South Africa. So one of the beginnings of the comedy thing is that, and I'm Jewish, that I'm a Jewish African-American. So if there's references to this as an African-American, that's part of that beginning comedy thing that you won't hear. But I believe this is when I get into the cancer piece.
In 1997, I was diagnosed with cancer. I spent a year and a half getting chemo, radiation, and had a fibula removed, and was in a wheelchair for 6 months. In 2001, I moved to the Valley. You know what really sucks? Moving to the Valley.
So this is a quick reference, the Valley thing, to people who lived in LA, where there's this big divide between the city and the Valley, and nobody wants to come to the Valley, which is a little bit like West Side, East Side, Seattle.
Cancer, I still live in the Valley. So let me give you some of the reasons why cancer isn't all that bad. My birthday, July 2nd. Yeah. Okay. What's that astrological sign? Yes. That's the astrological sign. I'm in perfect balance. Looking at me when I went through my treatment, I realized what it was like to be a bold and beautiful African American, like my fellow brothers, Kobe Bryant or Michael Jordan. A friend of mine said, "That's crap. That's not true. You look more like Woody Harrelson and white men can't jump, and natural born killers. I just looked at him and said, do you know what it's like to kill a person? Never said that again. Now, when you go through treatment, the beautiful thing about it is you can eat whatever you want without gaining weight. Thank you, chemo-sabi. Now, way before Brad Pitt was cruising around in the Prius saying, I'm saving the universe, I was cruising around in a wheelchair. He was generating minimum carbon emissions. I was generating zero. So I was much better environmentalist. Yeah. All my life, people had expectations of me. Like, you're going to marry a nice Jewish girl, or you're going to get a good job, translated to, or you're going to make lots of money. When I got sick, there were no expectations of me. I could do whatever I wanted. I could take acting classes and comedy classes, things guaranteed to make me no money. So after a while, I got really tired of cruising around in my wheelchair. It just wasn't going fast enough. So I decided to get one of those little mobility scooters, you know, like George Costanza did in the So there I was cruising around in my geriatric mobility scooter, and I almost was tempted to join a geriatric mobility scooter gang. The problem is we couldn't decide what to put on our jackets. Do we put Hell's Almost Angels? Oh God, not quite ready.
Okay, so that was one of the examples of when I went through treatment the first time of really taking that situation and all the bad things that happened and using art as Lindsay had previously spoken about, a way to transform that situation, a way to tell a story, a way to share what was going on in my life and own it as opposed to have it own me. So let's jump into the art world. So if you're looking at classical art. So one of the things that happened during my treatment is I always like to document things, partly because it helps when you talk to your provider about what's happening by taking pictures as opposed to trying to describe things and having them try to determine what's going on. But also just to navigate my journey and to remember the journey. And as I was going through this, especially when I lost my voice, I was like, how do I tell my story in a way that is not going to be offensive to people, not going to look really nasty, but be able to transform what's going on. So one of the things that happened to me was I had a blood clot, a DVT, as part of my treatment, and I was put in blood thinners. And what would happen on a regular basis is I'd have these really serious nosebleeds that would last for 30 minutes, 45 minutes. So I would own the fact that I had the nosebleed. I would control it by learning how to put pressure on the nose to stop the nose from bleeding. But it still happened on a regular basis. But what allowed me to really start to appreciate what was going on is to transform what I had into something more artistic. So the image on the left is the original picture, and the image on the right is the beginning of a process to transform that into something interesting. And one of the things that I enjoyed was Andy Warhol by the artist to show things in bright colors and series of things. So I found a photography instructor who was helping me through this and helped me create this montage of various images related to the blood splatter that took place. Another version of that is this one that is more of a subdued view of the blood splatter things. So just a warning, the next picture is pretty nasty. So if anybody has some sensitivities, close your eyes and I'll let you know when we skip past it. But one of the things that happened during my treatment is I had all these sores over my entire body. Incredibly painful. When I took a shower, it felt like somebody was pouring acid over me. When I used a towel to dry myself off, it felt like somebody was using a vegetable scraper or a cheese grater on my skin. Fortunately, I found a bamboo towel that allowed me to dry myself off without excessive pain, but it was an incredibly painful experience. And I was trying to figure out, how do I take, especially the picture on the right, and turn it into something that's a little bit more aesthetically pleasing. And when I looked at my body, I was thinking, wow, that looks like craters. Well, where would you have craters but on the moon? So this was the transformation. So the left picture was that original picture that I showed you on the right, with a picture that a friend of mine took of the moon, and then did a comparative view of the body being transformed into the moon next to a beautiful moon. My legs, during the treatment were really bad. They would weep a lot. You can see on the right side the leakage from the leg that was happening with continuous blood basis, completely red, swollen, and painful. So I thought, let's turn it into something a little bit more visually appealing, a little bit more color, not seeing all the nastiness there, and see where that takes us. And then the last thing was really looking at the comparison between common objects in society and the treatment I was going through, or the effects of the treatment I was going through. So the picture on the right was an infection I had in my right leg as a result of my chemo. So it really started as a small infection, spread, and then went pretty much up most of the right side of my leg, almost up to the knee, with tendons showing on the right side there. So I looked at that and I said, what is it that looks most common in terms of color or structure to what I had on the right, and found a blood orange, which has that same kind of white yellowish tint, like you would have with the tendons and redness of the raw skin and blood there. So that is the journey I'm sharing with you today. I'll pause and see if there's any questions I can address, or any questions for Lindsay, and go from there. And I'm open to any questions, so don't feel like you have to be limited in any way.
I'm just going to thank you again, Howard, and give people time to muster up some questions. I've heard your story multiple times, but I still love listening to it. And I liked I even got some art surprises today.
Hi, Lindsay. Hi, Howard. My name's Catherine. I'm on Inpatient Harborview Palliative Care as the chaplain. And I just wanted to say a huge thank you for this talk and this unusual and wonderful topic, and for kind of rounding our year out with some art. And Howard, I wanted to say I really appreciate you giving us the chance to engage with your art and your comedy and your journey. I think this kind of meaning making where you share more of your story with clinicians is really unusual in this kind of work. And it's really only in clinic where we get to have the kind of longevity relationships where that is exposed. So I just wanted to say really thank you for helping us make meaning of what your journey has been and up until this point.
Welcome. One of the comments I just want to make with that is I was in healthcare for a while on the business side of it, but one of the things that became obvious is historically physicians did things to patients or told patients things, and I think as we've navigated through the world, it's really a partnership, and it goes back to the control thing, where a physician is a coach, it's a consultant, it's an expert who's helping that patient on the journey. But it really is a collaboration between the patient and the provider. And the more that we can kind of equalize that relationship and realize that, I think that the more effective we'll be in terms of results and healing. So I don't know if there's other questions, but I just wanted to kind of reiterate some of the points, Lindsay, you made in the beginning that kind of tied to my presentation. If any questions, just jump in there. But bunch of things that Lindsay spoke about, dealing with trauma and how to deal with trauma and how to address it. So, the owning, controlling, and transforming. Critical to be aware and be present. So one of the things I say about myself is I tend to be very open and like people who are incredibly positive. Yeah, when I've been dealing with people in other situations, I've heard the word toxic positivity. So knowing that what's positive for me and what I really enjoy and appreciate may not be right for other patients, and meeting with them where they at is critical. Some of this collaborative work that we spoke about between a patient and provider is critical. So Lindsay had spoken about patient-centered decision-making and helping the patient make the decision as opposed to necessarily telling the patient. Once again, this depends on the patient. Some patients want to be told and they don't want to deal with that. In my case, I really want to be involved in that decision. So learning about the patient is critical. Lindsay spoke about empathy and the art of caring. For me, when I get sick, I feel less than human. I feel like a pariah. I feel like the other. When I've got stuff all over my body, I feel like people don't want to get close to me. And so just human touch, and I know this is touchy or a cautious issue in the medical field or any other fields, but just a human touch, a hug, makes you feel like you're not less than human. It makes you feel like you are human, that you're whole and complete, and it really makes a difference in terms of care. The ability to tell your story instead of keeping it in, and whether that's through storytelling, arts, comedy, whatever the case may be, and to find out who can help you with that journey, whether it be counselors, whether it be providers, anything else, but being able to say what's going on in your world really helps with that. And she spoke about fear being something that can be explored and manipulated. So as I was going through this journey, all these things that I use, whether it be comedy or art or spoken word, are things that you can manipulate and explore and overcome that fear. The one thing I would love to explore that we've spoken about is how do we take this stuff and help caregivers and people who are dealing with the loss of a loved one, because they are so critical in the process and many times overwhelmed. And since they're not the ones suffering, people don't really focus on them, but I think in many ways they're the ones who really need care. And then the last thing is just having art in the hospitals. The patients were able to see some of the work displayed in the hospital, or especially if they were to pass, memory in a hospital of what they contributed and a piece of them left behind, I think would be very important. So I'll pause there, and I know we've got less than a minute, but any other questions? Well, Lindsay, I'll let you close out otherwise.
Thanks, Howard. Thanks so many times for sharing your story. And thank you, everyone that's on the call today, for being part of today's story.
Thank you, Lindsay. Thank you, Howard.
Thank you.
I am going to